I'd like to thank Professor Ashraf for this
Dije que se podían poner una imagen de los colores antes y después y que la gente pensara que
مش انا اللي بتكلم عنها.
إلى أن أنت ألفت
Thank you again, Professor Rida Wasamra, my brother, for this kind invitation. I'm going to talk about rare complication of a common surgery. First, I'm going to present this case of a 26 years old male patient, computer engineer, coming after problem in his surgery or after his surgery, LASIK. The preoperative refraction was -6 and -0.75 in the right eye, the left eye -5.5, -1, and with normal pentacam. This is the right eye of this patient with a problem. He had the LASIK procedure done 3 weeks ago by other surgeon, my friend, which was uneventful in both eyes. But 1 week post-operatively, the uncorrected visual acuity was very low, 20/200 or 0.1 in the right eye and 20/20 in the left eye. He was diagnosed as DLK, and the primary surgeon did flap lift and interface wash with the use of steroids. He was on hourly topical prednisolone acetate eye drops with no response or no improvement. He was sent to me with this picture after 2 weeks from the wash or 3 weeks after the primary surgery. The uncorrected visual acuity was 20/100 in the right eye. The refraction was +5.5 and -2.5 with the corrected visual acuity 2800. The intraocular pressure was normal in both eyes with this picture in the cornea. This was the picture after 3 weeks and after 2 weeks from flap wash with steroids, and again with topical steroids hourly. So, what is your diagnosis? What is the next step in the management? To continue on intensive steroid therapy, or to gradually tapering the steroids, or to do a flap re-wash another time, or to give him systemic steroids, or to give him topical non-steroidal anti-inflammatory drugs. So what is the diagnosis? The diagnosis here was central toxic keratopathy. DLK or diffuse lamellar keratitis is a well-recognized syndrome of inflammation localized to the flap interface after LASIK, and this very common after LASIK to have this picture in the upper photo like that. It's diffuse under the flap, and at the same time the units are minute granules, or sometimes called sand of Sahara if it's aggressive. But in 2001, 3 cases were thought of as extreme form of DLK, and were termed central lamellar keratitis and subsequently termed central toxic keratopathy. The picture of central toxic keratopathy was published in many papers in the center of the cornea, in the pupillary area, in the area of maximal laser ablation, with some cracks or some wrinkles in the flap, with the flap clear. So the incidence of central toxic keratopathy is 0.016. This is a very rare complication, as you can see, and it's not associated with anterior chamber reaction or ciliary injection. It's very calm eye. It's non-inflammatory opacification of stromal bed while the flap is spared. So it's completely different from DLK. DLK or diffuse lamellar keratitis, it's an interface reaction. The flap is spared and the stroma underneath the stroma is spared, but the reaction is in the interface. Here we have some sort of non-inflammatory opacification of the stromal bed. This is the anterior segment OCT picture of the cornea with a case of central toxic keratopathy. As you can see, the flap is completely clear, and there is opacification and collapse of the stroma underneath. The pathogenesis, up till now, it's not well known, but there may be an enzymatic degradation of the central stroma resulting in corneal collapse. It's toxic reaction to some substance that undergoes photoactivation by laser, and always in the area of ablation, suggesting that ultraviolet laser energy plays some role. This explains why opacification is usually well-centered, as it coincides with the area of maximal laser application. Does not recur on enhancement. So if you have a residual error, you can do enhancement with no fear of recurrence of central toxic keratopathy. So it's not intrinsic patient response. Tissue loss and collapse of the central cornea was due to keratocytic apoptosis, and this is the pathogenesis. It's some sort of apoptosis of the keratocytes in the underneath residual stromal bed. This is followed by rapid increase in the thickness within 5 weeks by keratocytic proliferation. So it's completely different from what we know before, that we have collapse and then opacification of the stroma, some sort of scarring, and after then you can have clear cornea and thickening of this cornea again. So clinically, the onset is usually in the first week, 3 to 9 days, with circular opacity associated with stromal folds, as you can see in the pictures, especially the middle one, with hyperopic shift due to flattening of the cornea due to collapse of the stroma underneath. Decrease in the rate of thinning at the 1 week period, followed by rapid increase in the thickness within 5 weeks. It's cleared within 2 to 18 months. البيشنت بعد كده بيتحسن في خلال من شهرين إلى سنة ونص. بيتحسن يعني again the cornea regain its clarity and the cornea get again thicker. This is a picture or paper talking about the topographic or tomographic corneal profile analysis of central toxic keratopathy, showing the early in the picture A, number A. This is the early CTK, improving with time B, C, D. At the end of the picture, you can see the cornea again back to near normal thickness and back to the clear position. Again, we can see the changes in the corneal tomography. In the early, there is marked flattening here in both eyes, in the right and left eye, and after some months, after a few months, the improvement in the corneal topography with decrease in the flattening of the cornea. To differentiate, you have to exclude or to do differential diagnosis from diffuse lamellar keratitis. Is completely different. There is some sort of irritation and foreign body sensation in DLK. It's not localized, it's diffuse as the name indicates. The steroid responsive can improve with steroids within days or weeks, and inflammation confined to the interface, not associated with stria or hyperopia because the underneath stroma is intact. Also, we can differentiate it from the corneal infiltrate or infection post-LASIK, which is inflammatory with some sort of discrete inflammation involving the flat and the stromal bed, because it's an infection spreading above and below the interface with fine appearance of the individual inflammatory cells. Also, we can differentiate it from epithelial ingrowth, and epithelial ingrowth, you all know the picture of this white opacities or white cells that are in the interface. The management here is to exclude the other differential diagnosis and to do careful follow-up. Steroids would delay proliferation of keratocytic or keratocytes and delay the improvement in hyperopia. So we have to stop steroids or to do gradual withdrawal of steroids because there is no rule for improvement in CTK. None of irrigation, re-enhancement, or flat lift with reposition improving the outcome. So there is no rule of surgery. even in you are going to do some sort of irrigation, you are not going to do any improvement in the outcome. Still, we have peripheral toxic keratopathy, and this is another case report that the reaction may be not in the center, or sometimes it follows the LASIK in the periphery. And we have cases of central toxic keratopathy following PRK and cross-linking. We see these cases, especially in cross-linking, as the picture, the upper picture showing us, and this will improve with time without any intervention. To conclude, CTK is a non-inflammatory necrosis of the central stromal bed. There is a limited rule of surgery, and patient requires counseling because no effective treatment is available to speed up the recovery, although the final visual outcome is usually good. If you have residual hyperopia, you can do enhancement or retreatment with good outcome in these cases. And thank you very much. طبعا بس قبل ما اخلص، هي الحاله دي بتبقى مشكلتها ان البيشنت cannot see properly لمده شهور، وساعات بيبقى سنه او سنه ونص. معنى كده ان العيان ده هيفضل في رقبتك بيشتكي وانت مش عارف تعمل له حاجه. تقنعه بقى انك تستنى سنه وسنه ونص ازاي؟ هي دي المشكله اللي احنا بنعملها. شكرا مره ثانيه.
Thank you very much.